Nothing contained in this podcast should be considered a substitute for professional medical advice. This content does not represent our respective employers and is purely the opinion of the podcast hosts. We are not your personal medical providers. Sorry, friends. So, if you have any questions or concerns or seeking advice, diagnosis, and or treatment, please seek individual, personalized advice from a healthcare provider in your area. We are not liable for any risks or issues associated with using or acting upon the information contained in this podcast. This is intended for educational and entertainment purposes only, so enjoy the ride. Welcome to Medical Media Mixer, the perfect cocktail. I'm Nicole Peniston, licensed psychologist.
And I'm Tara Prisco, physician assistant. You're laughing at me because our internet is all messy and
there's a little bit of a delay.
Like pauses.
That's okay. It gives us room and space to breathe and to talk and to think, to process.
So what's interesting is actually your voice is okay, but your video is glitching on me. So I just get you in these cool poses.
Awesome. That's what my favorite thing is to have cool poses while my voice is calming and soothing and reaching all of you.
I see you're wearing your green today.
I am, and I made Lucky Charms cookies and brought them into work. And and I have little, you can't see them under my headphones, but little shamrock earrings in. And my hair is now red, so I'm feeling super Irish, even though I'm only a quarter Irish. Not even that.
You're more than I am. So on Ancestry, I'm only 9%. So
I mean, if I looked it up on Ancestry, I'm probably less than a quarter. That was just off the top of my head.
Yeah, I mean, you have to think about the math and the way it works down. So I did the backwards math. So it means my mom's 18%. And my grandmother was 36% or whatever.
Wow. That was some good math right there.
That's some backwards math there.
It is.
And my children are only 4.5%. So.
Look at that. You're so good. My Ancestry was the most anticlimactic thing ever. I kind of already knew. And then I was like, ooh, maybe I'll find out new information. I didn't learn a single brand new thing. Everything that came up on there, I already knew. And I was just
you did the DNA?
Yeah.
Yeah.
I knew my mom's family and DNA. I knew my dad's. And as expected, it came up that I was 52% Caucasian and 48% African American. It was like, wow, who would have known by looking at these two people sitting in front of me? Yeah, there were no surprises. It was anticlimactic.
Mine is such a mishmash. So it's like, apparently there's Slavic in there, which I think that's the Czechoslovakian. I guess maybe it goes under that. And then a lot of English, some Scottish, a little French, lots of German, mostly German. And then the Irish is in there. But it's more like my mom has like decades and generations and hundreds of years of history. My dad was like, I don't know. I think we're this.
Yeah,
my mother's French Canadian. My father is Czechoslovakian, and the rest, I don't know. So,
I know. It's crazy.
Oh, my goodness. All right. Couple of things before we get started. So this is going to come out. So we're talking about St. Patrick's Day. So obviously this is mid-March, but this is going to come out first week of April.
Mm-hmm.
So we had discussed that we're going to try and run a contest, which we will put up on Instagram only because we need to kind of keep it in one place. But we'll mention it here as well. So the whole month of April, so from the 1st till, how many days are there in April? 30?
More than 29.
You see, that's where it froze and I didn't hear you. But yes, whatever amount of days you said.
She'll find out later, folks.
So I know we're going to do this hashtag contest and we're going to make it sort of a little fun thing to also have competition between the states that listen to us. So right now, as of this moment, I'm going to give you just the stats for March because that's what I got for mid-March currently. And I'll mention the countries too. But all right, so first out, countries that listen to us is 92.3% the U.S., 3.39% the U.K., 1.69% tied Canada and Russia, and 0.85% Ireland. So I'm not sure if anyone's going to overcome the U.S. on that one, but hey, give it a good try. Tell a friend. But in the U.S., as far as the states go, there's a little more room that movement can be made. So our home state of New Jersey is at 55.05%. Okay.
Okay.
Florida's at 14.68, North Carolina 7.34%, South Carolina 6.42%, and then Delaware, New York, and Pennsylvania are all tied at 3.67. Hey, Pennsylvania friends, you were like number 2 the first month. Where'd you go?
Huh.
And Michigan, which I think I know who it is because I have friends in Michigan, is 1.83%. California, Massachusetts, Virginia, and Washington State are all tied at 0.92%. So, some little friendly competition. What states can get themselves moved up in the rankings? And so the contest will be go on Instagram, snap a picture of your screenshot of your phone or your car while you're listening to us, and say, I hashtag. I'm
hashtag medical media mixer.
Hashtag. All right, let's do that again. So, I'm listening to hashtag medical media mixer in, and then whatever state, country, wherever you're listening, and try and push yourself up in the rankings.
Wherever they're listening, or wherever they are when they're listening.
So I don't know what you're saying. Wherever they are when they're listening. What did I say? Wherever we are?
Well, I'm just thinking, like, if someone lives in New Jersey, but then is commuting to New York to work.
True. True.
That's some interstate fellows.
And so there you go. And then what we'll do is we'll take all of those entries. So at the end of the month, I'll be able to look up hashtag medical media mixer, and each entry will become an entry in a raffle to get a prize from us, which we'll announce for sure when that happens. We'll announce who it is. And the contest rules will be posted on our Instagram page so that it's all there. And we'll announce the winner at that time. And hopefully this helps to kind of spread the word a little bit and a little friendly competition. Let's see which states can move up in the rankings.
Yeah, and it's going to be a pretty cool prize. So it's definitely something that our listeners will enjoy.
Yes, it is something that I am working with to maybe craft our I'm hitting my microphone. Our signature medical media mixture cocktail. I think it's inspo for that. We'll give you the details when we are ready, but I think that this is going to be inspo for our cocktail, our official medical media mixer.
Are we going to call our official medical media mixer cocktail the perfect cocktail?
That would be
That's
smart.
our tagline.
That's a great play on words. You're so smart.
That's our tagline.
How we keep you.
I try.
All right. So I think you are going first today, and hopefully if I am slow to comment, it's because I can't hear or see you. But hopefully, because this is being recorded separately, your stuff is being recorded on your end. So hopefully we're good to go.
Okay. So my drink today is called the Welcome Home. It is, I'll show you a little picture. Nothing really that special to look at, just a pretty drink, very tasty already. I've been sipping on it as we were chatting and getting ready for the podcast. But the Welcome Home, courtesy of wholefully.com, WHOLEFULLY.com. And it is containing 1 ounce of gin, a half ounce of lemon juice, 4 ounces of champagne, 1 ounce of simple syrup, ice, and a brandied cherry. I didn't have a brandied cherry, so I used a maraschino. Follow your heart on that one. What you do is you combine the lemon juice, gin, simple syrup, and ice into a shaker. Shake well for 10 seconds. Pour the champagne into an old-fashioned glass. Add the mixture to the champagne. Add a cherry and enjoy. So you may ask, what am I going to talk about if the name of the cocktail is the Welcome Home? I am going to talk about agoraphobia.
Okay.
I know.
I love my home.
Exactly. Welcome home. So several weeks ago, I was trying to plan for a particular episode. I wasn't really finding what I was looking for. And as I was puttering around on the interwebs looking for good resources, I came across a television show called Found. It is a procedural drama on NBC. I watched it through Peacock. Yes, NBC is Peacock. And so the show originally premiered in October 2023. I know I'm late to the party. I just found it this year, 2025, but it is now on season 3, I believe. Or yes, so season 1 and 2 are out and season 3 is TBD. So the premise of the show is that the lead character, Gabrielle Mosley, she is according to Wikipedia, she is a public relations specialist and a crisis manager. They never fully define what she is, but she owns this organization that basically is a bunch of vigilantes who find missing or kidnapped, essentially persons of color, people that the police may not be as engaged in solving their cases for. This is when this organization swoops in, does all the dirty work, solves the crime, saves the day every episode. So time after time again, the police are either not caring about it or befuddled. And every time Gabby and her team swoop on in and they get the job done. I will say when I watched the first couple of episodes, I was like, oh, this is such a great show.
But public relations and crisis. I'm not really sure how that is solving crimes.
Well, I mean, she's solving them, but not on the up and up. She's using some techniques that are not necessarily above board. Like one person in her team, who I'm going to be talking about today, he is a hacker. And so he uses his tech and hacking experience to help triangulate phones and locate people and all that cool stuff. Surveillance, all of those things that are wonderful skills to have, but he's not working with the police. He's working in his house because he has agoraphobia and he doesn't leave home. So that's just one character on this team. She's got some other characters. One guy is a military vet who is no longer working with the military. He's got some mental health issues of his own. So that's another thing. Everyone on this team has had some really negative experiences in their life, and that's kind of what brought them together and make them want to work towards helping people in the future. So there's a few other people on the team. I'm not going to go into all of them because it's who I'm talking about today, but it's a good show. I like it. I suggest it. It's a little hokey at points. Like every time Gabby finds somebody, she says the same thing. I'm Gabby Mosley, and I'm here to save you. And it's like, really? You said that the last 17 episodes, but okay. We get it. Everybody knows you're the one who saved everybody.
That's the formula.
Yeah. But it's a good show overall. My favorite part of the show is the delicious Mark Paul Gosselaar. Even though he plays a very, very bad guy, he does it very well. So Mark Paul Gosselaar can still get things done.
We're going to throw it back eventually to Saved by the Bell. So
of course we are. Of course we are. But yeah, when I first saw it, I was like, wow, this show brings Zack Attack to a whole new meaning. And if some of our listeners have watched the show, they know exactly what I'm referring to. No spoilers, but Zack is attacking in a different way in this show. So as I was saying, I'm going to talk mostly about one of the main characters whose name is Zeke. So Zeke Wallace, he is the tech expert on the team, and he has pretty severe agoraphobia. They don't say exactly when it started, other than at one point he had been abducted by a family member as a child, and ever since then, since being rescued, I'm assuming, he's really afraid to leave his home. And as far as I've watched, which I've watched the majority of the shows. There are 13 episodes in season 1. Looks like 17 episodes. No. Yes, 17 episodes in season 2. I would say I've watched 90% of the show. They never give the full story on Zeke so far, maybe TBD, but I'm assuming that they will eventually get to his full story. But he alludes to being abducted by his uncle. We don't know why. We don't know for how long. We don't know what happens. But Zeke's got some demons in the closet, and that has led to a very contentious relationship with his father, and his family is quite wealthy. So he has a very large trust fund that he is using essentially to help fund this organization that Gabby is running, plus pay for all his fancy surveillance toys and hacking techniques and all that stuff. So Zeke just chills at home, does the job. He's a pretty sweet character. Once you see him engaging with some of the other characters, he doesn't always get along well with them, but he's a good guy. You can tell at the core he's got his issues, but he means well. He wants to help everybody. There's some little romance potentially on the side with one person, and then there's definitely some flirtations with another person. And then you're like, Zeke, what's your deal? Who are you going to end up with? Will they, won't they? I don't know. They haven't yet. But Zeke, I think, is a unique character in that, at least from what I've seen, watching a lot of shows about mental health concerns and movies and things like that, is we don't often see an African-American man portrayed as having agoraphobia, which it does affect all races. So I thought that was unique. Most of the people in the show are persons of color, and the victims that they're going to find are also people of color. So I like that they're bringing those things to light. These are not quote unquote white disorders or white people problems. But I feel like we don't necessarily see the true emotional experience of these things with people of color portrayed in the media. And so I really liked that they were doing that. They were exploring Zeke's issues. So I think you were going to say something, and then the dreaded.
It's okay. I froze. You froze. We're good. Keep going. I'm listening.
Okay. So what is agoraphobia? Any ideas? You want to chime in while we're not frozen?
We were. So I had you smiling. And it was any ideas. I think, like I said, we're recording fine separately. I just can't really hear you sometimes.
It's okay. So I was asking you what agoraphobia is, but now I'm not going to let you answer. I'm just going to tell you. Agoraphobia is a fear of places, usually larger spaces, larger places, but it can extend to avoiding places or situations that can cause someone to feel overwhelmed or to feel trapped or helpless or embarrassed, which in effect will result with someone not wanting to leave their home. So it's not necessarily a fear of leaving your home. It's more of a fear of public spaces. But because of that, that fear becomes so overwhelming that you just remain at home. Sometimes people are able to go out into those public spaces with a companion or a service animal or a family member, but other people, it doesn't matter who is with them or what tools they have, that actual just leaving of their home can be really upsetting. And so sometimes this can stem from a specific situation. Like I said, they alluded to Zeke having some trauma regarding being taken maybe from his home. Again, they haven't told us his whole full detailed backstory, but also what can happen is people can have a fear of embarrassment. So let's say you were out in public and you got very sick and weren't able to get to the bathroom and, embarrassed yourself in that way, or had a fall or an accident and now you want to stay in the safety of your own home. Maybe you've gone out in public and then gotten really, really lost, and that can be anxiety producing. And so in order to avoid that from happening again, you would want to stay home. And a kind of subset of the symptoms of agoraphobia, other than this fear, can be panic attacks. And so when you attempt to go out in public or attempt to go places, having a panic attack because the anxiety is so heightened. And so a lot of times people may then decide to stay at home to avoid going out because they want to avoid the panic attack. It's not necessarily about avoiding the spaces. It's about avoiding that overwhelming feeling that they get. So typical symptoms of agoraphobia can be fear of leaving home alone or leaving home at all, difficulty dealing with crowds or waiting in line, enclosed spaces like elevators, small stores, movie theaters, open spaces like parking lots, bridges, malls, or using public transportation, so bus, planes, trains, things like that. What the biggest thing with this is that makes it different from, let's say, social avoidance is that the fear and the anxiety is out of proportion to the actual degree of danger. So with social avoidance and social anxiety, you're avoiding these situations because you don't want to be embarrassed. So you're not going to go speak in front of the classroom, or you're not going to go and, be the star of the show, but you might still go and just kind of be a wallflower or hang in the back. Where this, you don't even want to be in those situations. So you avoid the situation completely. And then if you do get put in those situations, it's so upsetting, it's so overwhelming that you're going to have a panic attack, or you're going to be so overwhelmed that you can't enjoy it. You can't enjoy the ability to get out of your home and overcome that part of the fear, because then there's something that's coming next, that panic attack. And then, of course, if you're struggling with leaving your home or having these panic attacks, it can definitely impact your social life. It can impact your work life if you're not able to work from home. It can really limit all the things that you do day to day that we don't even think about. So one thing that comes up a lot for Zeke in these episodes when they're not necessarily focusing on him is he has to have food delivered to his house. He has to have groceries delivered and packages delivered and things like that. But where he lives, a lot of times the delivery people will leave things on the steps. Well, in order for him to get the stuff on the steps, he has to step outside of his home. And so he has a panic attack and he can't do that. So he's got one of those little old people grabbers, and will grab the packages. I don't know if you've seen the long sticks with the little pinchers on the end. He'll use that to pick up his food or things like that.
Oh yeah.
And then there's one particular episode. I didn't write down which episode because each episode you get a little flavor of Zeke's agoraphobia, but none of them have fully focused on it yet. There's one particular episode where there's some sort of emergency and he needs to get out of his house. And so he opens the door in a rush and he goes to rush out and then just gets hit with this intense panic attack. And he's dizzy and he's lightheaded. maybe lighthearted too, lightheaded, and his heart's racing and he can't breathe, and he kind of like presses himself up against the wall and is like trying to calm himself down, and then he goes again to try to go up the stairs to leave the house, and he passes out, falls, and hits his head on the steps. This is a traumatic brain injury, at least in the way that they show it. Like, he's bleeding, he's unconscious for hours, and then, somebody just stops by his house to check on him, patches him up, shoves a Band-Aid on his head, and sends him back off to his hacking work. And I'm like, I don't know if that's a good thing for you, my friend. At other points in the episode, Zeke has another medical emergency that I'm not going to go into because it's a spoiler if you watch the show, but he does get taken to the hospital. And then when he wakes up in the hospital, he has like a full freak out because he's in the hospital. He's not at home. And to the point where it's so severe that I don't know how realistic this is, but they actually talk the hospital into discharging him home because being in the hospital is more distressing than whatever medical situation he's going on to. So,
oh, wow.
So that's how intense his agoraphobia is. Now, a panic attack, a lot of people might not understand exactly what a panic attack is. It's more of the physiological symptoms of anxiety. So that is rapid heart rate, difficulty breathing, feeling like you're choking, pain in your chest or pressure. Some people say like they feel like they're having a heart attack, lightheadedness, dizziness, feeling shaky, numb or tingling, excessive sweating. You can also have flushing or chills, upset stomach, diarrhea, loss of control, and feeling like you're dying. And so a lot of times people may present to the emergency room for panic attack thinking they're having some sort of medical disorder. And that is very common. A lot of ERs will see people for panic attack because the patients think that something has gone terribly wrong with their health. So in terms of prevalence of agoraphobia, according to this is by the NIH, their National Comorbidity Survey from 2001 to 2003, so this is a little bit old, it said it estimated that 0.9% of U.S. adults were diagnosed with agoraphobia within the last year. And then the past year prevalence of agoraphobia was similar for males and females, so 0.9 for females, 0.8 for males. So not really a big discrepancy between genders on that. And then it was estimated at that time that 1.3% of U.S. adults have experienced agoraphobia at some point in their lives. Very small percentage of people, but I feel like it's something that, for the excitement and the media of it, we've seen a lot of it in movies and TV shows versus actually knowing real people.
Is there an average age of onset or something that you know?
So this, if I'm reading it correctly, it says it can begin in adolescence, so between 13 to 18.
Okay. Yeah, I can picture one patient. I'm sure I've had more than one, but one patient in particular who's been going through that, and they have a good family support who will drive them to an appointment and that kind of things. They know they have to, but it's difficult. Someone can't do their job. They can't go out to their supermarket. They can't go to their kids' school. Things like that can come up. It really, obviously, we don't realize how much we need to be going into the outside world.
Right. And I wonder, I don't have the data on this, so this is just conjecture. I wonder if people with agoraphobia are now almost allowed to avoid some of those social situations more now because we have things like Zoom and people are allowed to work from home. It does almost in a way support that fear by having these options instead of being forced to leave your home.
True. DoorDash, Instacart, working from home. All of it, yeah.
Which at the core, if someone's truly debilitated by it, this is not something that you can just change with the flip of a switch. You're going to do things like exposure therapy, which is you gradually work up to getting outside. So there's one episode with Zeke that's a really good episode where he really wants to leave his house. And he has this whole talk with this other character about the things that he misses about being outside. And at this one point in the episode, she says that she really enjoys just standing out in the rain and enjoying the rain. And so he's really thinking about her. He's kind of alluded that he's got like a little bit of a crush on her, but they never really say anything. Hopefully TBD on that one because they would be super cute together. But there's this one episode where it's raining outside and he's had a rough day. There's been some stuff going on related to larger plot lines, and he opens his door and he steps like slightly outside and extends his hand and feels the rain, and you just see this like look of just joy overcome his face, and all he did was like put his hand out far enough for just his fingertips to touch the rain. But like for him, that would be step one in exposure therapy, where, okay, you haven't left your house, but you're trying, you're taking one step forward that you hadn't done in months or years. And that's really what's difficult about exposure therapy, especially for agoraphobia. Depending on how long someone has had this and how severe it is, it can take a very, very long time to get someone back into the daily life that we all expect someone should have, especially if there are these other supplemental things that we just talked about that are making it easy to stay at home. Like with Zeke, he gets all of his food delivered. So he doesn't have to go to the grocery store. He doesn't have to go to a restaurant. He doesn't have to go out. But maybe he's missing out on part of his life by going out for drinks with his buddies after they solve a case.
Yeah.
So it's like there's things that even though he can function like this, is it really the best for his mental health? And he does come to question that throughout.
Is it typically the longer somebody's sort of stuck in this, the harder is to get them out? Is that kind of...
I would say yes, but I also think it really depends on a bunch of factors. I think it depends on what kind of triggered this disorder, the level of trauma that caused it, or if it was something that gradually happened over time. They gradually started pulling out from public versus just a one day, no more. I think it also depends, as with any mental health disorder, the person's level of distress and if they want to change or if they're happy with, staying in their home. If they're perfectly happy and content to avoid being out in public, they're not going to want to change. They're not going to want to do this therapy that's going to get them back out there. So there's a lot of factors to it, but I do think with anything, the longer we've been doing something unhealthy, the harder it is to change it. And so etiology, we're not really clear on where it comes from, but as I said, trauma does play a big role of it, but there could be a genetic factor. The heritability estimates are ranging from 48 to 61%. But those are also smaller studies because since this occurs so rarely, even if we studied everybody that we know is diagnosed with it, we're not really capturing the full essence of it because with any study, these are people who are voluntarily participating in the study, so they may inherently be different than people who chose not to participate in the study, which that's always a big thing in psychological studies. What is the difference between someone with this disorder and they want to be in the study versus they don't want to?
And it also reminds me too, though, of the whole, I think with OCD, we talked about this. Is it genetic or is it learned? So if your parent had this and this is how you always grew up, then is that because of an actual, genetic cause or a learned behavior?
Yeah. And so this one study that they're citing, they said a family history of panic disorder was associated with panic disorder with agoraphobia in offspring. But agoraphobia without panic disorder, there was no genetic component that they were finding. So it really depends on how it presents as well.
Right. And panic is so coming from the inside that I don't think that would be an observed. Nobody wants that to happen. That's not something you could make happen. So yeah, that kind of separates that out.
Although in the future, we are going to talk about when people fake disorders. So that's a different issue. But
yes, other
other contributing factors that they say can be lack of paternal warmth. I'm sorry, not paternal, parental. I'm not trying to be mean to the dads out there. Lack of parental warmth, parental overprotectiveness, childhood fears or night terrors, early life experiences of grief or bereavement, and then an unhappy or traumatic child. So having those difficult things early on also kind of makes you not want to trust the world that much to go out there either. And then, let's see, we talked about all of the physical symptoms. We talked about treatment. There's other types of medical treatments that you can use, like benzos, which we've talked about, how that can be not always the best choice. A lot of the SSRIs are not really as successful in remission of agoraphobia symptoms, but can treat some of the anxiety associated with it, but it's not necessarily just going to get rid of the agoraphobia itself. And as I said when we started off, agoraphobia is a type of anxiety disorder. So just because a medication works well for anxiety doesn't mean it's going to work well for all the types of anxiety or all the things that are happening. SNRIs can also be just as effective as benzodiazepines or tricyclic antidepressants, but a lot of those medications have a lot of side effects, so they're not always the first line choice for some of those things. But we do know with things like agoraphobia, with panic, a lot of the best outcomes, it's going to be a combination of the medicinal treatments, the psychopharmacology, as well as therapy, because the medication is only going to do so much if you have these negative cognitions about going out in public. It's not going to get rid of your
Right.
thoughts. It's just going to make you feel less distressed by those thoughts.
Right. It did freeze a little bit when you were talking about the medications, but I'm not sure if you mentioned in there beta blockers. So blood pressure medications that we sometimes use. So for the panic end of things, it can't fix the full underlying propranolol, which is kind of an old blood pressure / heart rate medication, slows down sort of fight or flight. So we use that sometimes for situational things, if the patient either knows or, to have it with them in case it happens, or if they're going to walk into a situation that might have panic, then they would take it prior to going. So I've used that successfully.
Right. And that would be great to use when someone is going through that exposure therapy, knowing that they're going to be put in those situations that are going to cause those symptoms to escalate, versus using it just when you're staying at home and the thought of leaving is making you anxious.
Exactly. That makes sense. And then you don't get that feedback of the heart rate going up and all of that when you're doing the exposure therapy. So
exactly. And then there were some pretty interesting studies specific to anxiety disorders in African Americans versus Caucasian populations. And there was one particular one that I found really interesting. Those will all be linked in the show notes. But in general, 1 in 5 African American adults experience at least one type of anxiety disorder within their lifetime. So you can have more than one anxiety disorder. And then the most common anxiety disorders in that population are post-traumatic stress disorder, social anxiety disorder, generalized anxiety disorder, panic disorder, and then agoraphobia, with a lifetime prevalence in the African American community for agoraphobia being 2.1%. So that's nearly triple what we were talking about, the general population statistics for that. So I think there's a lot of work still to be done on that. There is a lot of distrust and mistrust of both the medical field, but also the psychological field for persons of color, with 100% understandability. And where I think we can work to address that is having more therapists of color working with people in their community, being more vocal, doing more outreach, talking about these issues affect everyone. Like I said before, these are not white disorders or white people problems. Everyone is affected by them, but it's just, if you feel like you're in a space to seek treatment and feel like you're getting the treatment you deserve and being taken seriously, versus being disparaged or blown off, as that has happened with a lot of people in minority groups, have not always been treated very well by medical fields and by psychological fields. So trying to break the stigma within the community, but then also changing the way that we're approaching everyone, not just people of color, but talking about what's happened in the past, what we need to fix, and doing better now. I think another really interesting thing that came up in these articles looking specifically at the disparity in those incidences was something that we don't necessarily take into account if we are not a person of color, is the effect of racial discrimination on anxiety disorders. You feel anxious because when you go out in public, people are treating you differently. People are not treating you in a good way. So that makes you not want to go out there. And that is totally understandable. We cannot turn a blind eye and say that this doesn't happen, because it's just not true. And so looking at and truly understanding the social aspects that are contributing to these disorders in these folks, and then how to change that, how to make it better, how to make things more receptive for persons of color to feel like they are seen, they are heard, they are not being discriminated against, and then doing what we can socially to end that discrimination, to change it, so that way everyone can feel safe out in public. Everyone can feel safe going about their lives, and then getting the help in a way that they feel is right for them. With respect to lifetime disorders in African American women, there's also been racial discrimination as well for any anxiety disorder. So all the ones that I listed before. And then the conclusion of that, so that study was done in, I just lost my citation. It was done in a year that occurred, citing references from 2022. So it was after that at some point, if they're citing those resources. Where is it? June 2023. There we go. And this was in the Journal of Affective Disorders. Okay. And then there's some older studies that I linked, one from 1999. But luckily in the field, we know this is not brand new information. We've been working for some time to try to address this disparity. Well, this would be interesting for you to know on your end, is the prevalence of anxiety disorders among African American and white primary care medical patients. So when people are just going to their regular office visit, being screened for mood and anxiety disorders, and then the disparity of people coming up with that. So we know things have changed in the primary care realm, where there are more mental health screenings happening in a typical visit than there used to be. But also at some point, it's like, well, how much time can you spend on that when they're there because, they've got pneumonia? You want to do a screening, but you're not going to spend your whole session then talking about agoraphobia with them when you're just like, okay, like, let's treat your pneumonia. So making the appropriate referrals to other professionals in the community, talking about how these are very treatable and manageable disorders. It can be difficult, but people don't have to live this way if they'd like to make that change. So that's what I've got for agoraphobia.
Nice. Yeah. I mean, something we definitely encounter panic. I certainly encounter panic. And like I said, I can think of one, maybe two patients who I would call agoraphobic, but it's just being, I think, open, hopefully, so the patients feel that they can approach you, in the primary care space, like there's simple things. And it's something obviously you hone your craft over years, but like body language, receptiveness, so they feel that they can tell you. And a lot of people hold this in and don't want to tell you about these, like you said, the stigma of mental health. And so I always try and like not be at my computer, turn my body toward the patient, sit back, relax, and listen. And you know what I mean? So that they feel that I'm engaged. And that's not like me doing something, I don't know. I think we talked about one doctor on the bug episode about, he does this, he does this. No, it's just something I've developed is I found patients are much more receptive when your body language is focused on them, looking at them.
Right. Absolutely. And that's something I've alluded to in other episodes, maybe even explicitly said, but the real magic of therapy is that connection between the practitioner and the patient. So whether you're going to primary care or going to a therapist or going to your GI doctor, if you feel like your doctor is listening to you, you're going to be more open to them. You're going to be more open to the treatment suggestions. And if you feel like you are being heard, you're going to be more comfortable in that. And so you're going to get better outcomes. That being said, it's not all about the patient. The practitioner has to do their part to be an authentic human being and pay attention to someone who's coming to them for help. Unfortunately, we've alluded to before, sometimes the way that our systems are set up, we're not always given that freedom and that time, but there are those little things that we can do. Like one thing that I do with every person that I see, or I try to do with every person that I see, is I ask them, is it okay if I type on my laptop while you're talking? If not, okay, then I'll write down notes on a piece of paper. I just want to make sure I'm getting down everything that you're telling me so I don't forget. Something like that makes the patient understand versus feeling like, oh, they're just staring at a screen and they're probably answering messages from somebody else or checking their email or Googling something where, sometimes there are people who are doing that, but most of the time we're just trying to take our clinical notes so we know how to inform treatment.
Right.
Yeah.
Exactly.
So that's all I've got for you. What do you have for me, my friend?
All right. So my cocktail, I'm more than halfway done with it already. So I think it's pretty tasty. It's called Eclipse of the Heart, which reminds me of the song Total Eclipse of the Heart, which reminds me of you because I don't know why. I think you've belted it out.
I would belt it out now, but no one wants that.
All right. So this is described as a layered, visually striking cocktail with a complex flavor profile.
Sexy.
Starts out with 1.5 ounces of gin, 1/2 ounce of amaretto syrup, 1/2 ounce of blue curacao, 1 ounce of orange juice, 1 ounce of black currant juice, which I literally had to order online and apparently is only made in the UK. 1/2 ounce. Well, hey, our UK listeners, get me some black currant juice.
Yes, I would definitely take some alcohol or juice or something fun from the UK.
1/2 ounce of grenadine, 2 ounces of tonic water, and 1 ounce of red wine, usually a dry variety. And so you have to layer this whole thing. So it's a little precarious. First, you do a highball glass and you fill it with ice. Start with the gin, pour that in first. And then you add the amaretto syrup and the blue curacao to that mixture. Then you're supposed to slowly pour the orange juice and then the blackcurrant juice to create a gradient, which I don't know if that section of mine had the gradient, but it's okay. Then you add the grenadine, which will sink to the bottom, making a red layer at the bottom. Then you have to top it with a tonic water, but to not disrupt the layers, you have to pour it over the back of a spoon, which meant that a lot of the stuff went all over my counter. But a decent amount made it in. And then same thing with the red wine. You need to use the back of a spoon to sort of, I didn't read that one correctly. Apparently the spoon was supposed to float the red wine, and I used the back of the spoon because the tonic is the back of the spoon. Apparently the red wine was supposed to be the spoon in the correct direction. But either way, the red wine stayed at the top. So that part worked, even though I did it wrong.
Really? That's funny. I would have thought it was
anyway,
too heavy.
It's actually pretty tasty. So you kind of drink through the layers. So the top was like winey. The middle is like orangey. We'll see what the bottom one tastes like. So Eclipse of the heart. So we are talking about the heart. There's a lot to talk about the heart. So we're only talking about one sort of diagnosis, which is probably the biggest one. Coronary artery disease, and heart attacks. So we cover Grace and Frankie. Have you watched Grace and Frankie?
Not all of it, but most of it.
I love it. These characters are just so adorable. And the ending, it ended the series, and the ending of the series was really nice. It like closed things up very nicely. So I like that when I get a series that actually ends with like an intentional ending.
Yeah.
So it is an American comedy series, and it's created by Marta Kaufman, which I know is a big creator of a lot of TV shows, and Howard Morris, and it was on Netflix. And it stars Jane Fonda and Lily Tomlin, as well as Sam Waterston and Martin Sheen. So it's a pretty big cast right there, like huge names.
Yeah.
And it was on Netflix from 2015 to 2022. So it follows Grace Hansen, who is played by Jane Fonda, and she's a sharp-tongued retired cosmetics mogul. And Frankie, who is played, of course, by Lily Tomlin, because she's the hippie, quirky artist. And so that's Grace and Frankie. Their long-term husbands, Robert and Saul, are successful divorce lawyers, and they all live in San Diego, California. But their lives are turned upside down when Robert and Saul announce that they are in love with each other and are leaving their wives. So comedy ensues, but comedy in a, I would say, dramedy sort of touching way. Lots of lessons learned, learning how to restart life in your 60s. So it's a lot of fun. So the women who really never, of course, we have the high fashion cosmetics mogul and then the hippy dippy woman. They end up moving in together because there's a shared beach house that both couples had owned together. And so they both move into that shared beach house because they move out of their respective primary homes that the husbands end up keeping. And so, it goes through all kinds of ups, downs, medical scares, family drama, and it's a lot of fun. So episode 1 of season 2 is called The Wish. So it starts out with Saul, who's played by Sam Waterston, and also like him from like Law and Order to him as this character is
totally
so
different.
He plays it sort of like nervous, panicky. I love him. He walks into the house and finds Robert slumped over the kitchen table and unresponsive. So, yeah, they cut to now Robert in the hospital bed on a monitor, oxygen on. He's clearly a bit loopy on morphine. His daughters show up. Bud and Coyote, who are Frankie and Saul's kids,
I love
show
Coyote.
up. I know. And they said they're going to take him down for a heart catheterization. The whole family's in the waiting room. It's all very involved. These families have grown up together. So even despite this whole upheaval, even the kids are basically like family. So, once they come out from the heart catheterization, this female doctor, actually, which I like that being portrayed, comes in and states that there are acute blockages in his arteries and he's going to need a bypass surgery. And they said they can get him into the OR in just a few hours. They actually, which is interesting, they do an endoscopic bypass instead of open heart surgery. So I'll touch on that later. It's not something you hear too much about. But basically, of course, this kind of a news changes him, a big fear of dying. He's scared. And basically he says that, I want to marry Saul like now before I go in for surgery. And so it is sweet. And so everybody sort of scrambles to get things done. They were supposed to have this actual wedding, but they scrambled to get things done and they end up getting married in the hospital. Mm. And, at the end of them getting married, they have the hospital bed being pushed away and there's like a just married sign, like with like stuff on the back of the bed. It's really sweet. So, basically Saul comes out into the waiting room after the heart surgery happens, says, they told me everything's going to be fine. They cut to Robert. He's in bed, oxygen mask on. He's asleep. Later, they show him with a nasal cannula, which is oxygen just through the nose, waking up a bit confused, a bit loopy, and then eventually waking up completely. And he's in much better spirits. And this kind of plays out actually over 3 episodes. So the main one is the episode 2 of that season. But then episode 3 and 4, sort of him finishing up. And by the end, he's joking around with the gay male nurses and they're having drag bingo in the hospital. Like it goes from him being scared, of losing his life to sort of this lighthearted thing by the end. So what happened to Robert? He had, typically what we would call a myocardial infarction, which is caused by coronary artery disease. So coronary artery disease is the leading cause of death in the United States. Mm-hmm. And it is estimated to be 1/3 of all deaths in the population older than 35 years old. So it's a lot. So 1.5 million cases of myocardial infarction, so that's an acute event, a heart attack, what we call a heart attack, occur annually in the United States. There are other, and we'll touch on, coronary artery disease in general, but MI, myocardial infarction, is that acute heart attack that we see portrayed in TV and movies. And when somebody says, I went to the hospital with chest pain, I'm having a heart attack. That's kind of what we call that. So, we've made big strides, but even with the big strides we've made, the total number of MI-related deaths in the United States has really not declined, even though other age-adjusted death rates have improved. So it's more frequent in Black patients compared to white patients. And that excess disappears, though, by age 75, and it sort of evens out as far as the death rates go. And surprisingly, actually, the Hispanic population is less than both the Black and the white population for actual death from MI. I'm not really sure what that is, but hey, that's good.
Yeah.
Any less death is less death.
Yeah.
So coronary arteries. So this is kind of like basics. Let's kind of define what's what. So the coronary arteries, when I show this to a patient, I use my hands, and they're these little finger-like arteries. And I'll show this in the camera. I'm not sure if it'll go on the video or not, but sort of that sit on top of the heart. And their job is to feed the heart muscle, because the heart is a muscle and essentially is a pump. And I explain this to a lot of my sort of blue collar men workers. I'm like, this is a pump. If this pump doesn't work, the things don't move. And I explain, in that way. But this pump needs power, and it needs those coronary arteries to feed that muscle, or else, like any muscle, without blood, it would die. Mm-hmm. So the coronary arteries, they come off your aorta, which is your biggest artery in your body. You have the right coronary, the left main coronary, the left anterior descending, the LAD as we call it. That's the one they call the widowmaker. So that, because it supplies such a big portion of your left ventricle, which is your basically most important part. So if that one gets completely clogged, that's when people say they could have a sudden death. And then there's the left circumflex artery. And so, any degree of blockage in these arteries could cause angina, which is chest pain that doesn't become a heart attack quite yet. Heart disease, heart attacks, and heart failure.
I always called her angina.
Angina. Yeah. I mean, there's a lot of things in medicine that, we all pronounce differently. Tinnitus and tinnitus. That's a big one.
Yeah. I always called it tinnitus.
You can ask different people. Everybody's going to call it something different. So, like we talked about briefly, blockages would be the most common reason, right, for a heart attack. But there is a small population of people who can have microvascular coronary disease, which means sort of off the tips of those coronaries. If you think about all blood vessels sort of like trees branching off, right? And if you get to those teeny little sticks, those tiny little trees at the end, those are those microvessels that in some people, particularly women, can cause actual tissue death if those are not getting blood supply. And so that's tricky, because you can do this catheterization, looks like everything's clear, but deep down at the little teeny tiny ends is where the blockages are, and there's not much you can do to just open those magically. So what is a heart attack? So we kind of just said a heart attack is a myocardial infarction, which is defined as irreversible death or necrosis of the heart muscle due to prolonged lack of oxygen supply, which is called ischemia. And so atherosclerosis, which is clogging of those pipes, basically, is one of the big reasons. Sometimes a little clot can get thrown into there, a little emboli. Coronary artery spasm. So this isn't like something physically blocking the hole, but basically if you think about like tightening of that pipe and kind of clamping down, or embolization, which is some sort of debris from other part of the body that can get thrown into there. And MIs have a pretty big, mortality rate. 30%, acute MI has a 30% mortality rate, and about 50% of those deaths occur prior to even arriving at the hospital. So if you get there, you're in way better shape than half your friends, okay? And then even 5 to 10% of people who survive still die within the next year due to complications, because say you can't get that heart muscle back, right? Then the overall pumping of your heart is going to be very, very much less, which again causes congestive heart failure. That's another episode, another day.
Which could probably also, if you're not fully pumping, that could lead to stroke or other issues not directly related to the heart.
All of it. Yeah. And just being in the hospital and being sick and then having rehabilitation. Like there's just so many things that come off a big event like this. And, so patients' prognosis is pretty variable. There are some things that play into that. Successful early reperfusion. So getting blood back there early. And so, and then after the heart attack, how much of what we call their left ventricular function. So that's their left ventricle, that big important one, how well that's pumping. And then whether they put on certain appropriate medications at discharge actually can improve, which is pretty standard now, but can improve their outcomes. Beta blockers, aspirin, and something called an ACE inhibitor. So those help prognosis if all those things are done.
So this may be off topic, but question. Why the big push for baby aspirin? What is that doing?
So that helps to stop your platelets from sticking to one another. And so, when we get to what atherosclerosis is essentially plaque buildup from cholesterol. Think about sticky, cloggy pipes, and then your platelet, one of them gets stuck there. And platelets, their job is to stop you from bleeding like in other places. And so they like each other. And then another platelet is like, hey, I'm going to get stuck there. And another platelet is like, hey, I'm going to get stuck there. And then hence blockage. So aspirin is helps to stop the platelets from sticking together.
Awesome.
So yeah, poor prognosis is age is a big one, advanced age, diabetes, having had a previous event of any kind, or just complications after having that poor, ventricular function at the end, and some, depending on what part of the heart it hits, essentially is going to affect your outcome. So, what do we know the typical signs of a heart attack are? What do we tell people? To go to the hospital if you have
chest pain, radiating down your arm, although when women, the signs are different. I know that.
Yep.
Difficulty breathing, shortness of breath. That's all I got.
Yeah. I mean, all
with
those
women,
things.
I've heard it could be jaw pain.
Yeah. I mean, so yes. So, and different people can experience it differently. People with diabetes are going to feel a little bit less. Women can feel it a little bit differently. The universal sign of a heart attack is sort of your fist over your sternum like this. That's sort of like, I'm having a heart attack. I don't know why, but it's true. And that's what people often look like if they're presenting very, very typically. But yeah, chest pain that's unremitting for 30 to 60 minutes, usually right at their sternum. So right in the middle, and can go up to the neck, the shoulder, the jaw, and down the left arm.
That's a long time, 30 to 60 minutes.
Well, yeah. I mean, so yes. Get to the hospital.
Yeah.
And people can call it squeezing, aching, burning. Some people call it sharp. Some people can actually feel like they have indigestion because some of those nerves and some of those things are very similar. So it can be mistaken for indigestion. And of course, opposite indigestion you can think you're having a heart attack. So either way, if you have pain like that, get evaluated. And like you mentioned, shortness of breath can be part of it, fatigue, dizziness, and sometimes you can have like nausea and vomiting and things. Okay. Vital signs, your heart rate might be fast. You might be in arrhythmia. Your blood pressure might be elevated. In severe cases, you're actually going to have cardiogenic shock. So your pressures are going to be low and you're going to be basically, not responsive. The way we diagnose it. So interestingly, we all know what EKG, we see, they put the leads on you, they get this readout, but what an EKG is essentially doing is just reading out the electrical impulses of your heart. So it can tell us a lot of things, but it can't tell us everything. So it can tell us that if the electricity is disrupted and shows certain things on the EKG, there's likely something damaging that piece of the heart. That's what we look at it for heart attack. And we specifically look for this one segment. So there's all these little bumps in the EKG. Again, whole nother class, but it's something called the ST segment. If the ST segment is elevated, that's a ST elevation, MI, STEMI. And that's pretty straightforward. Just don't stop it, go. They're having a heart attack. Other thing we look at is something called troponins in the blood, which are markers of muscle breakdown, specifically heart muscle breakdown. The problem is now we've got sort of this whole other classification of something called an NSTEMI, which is a non-ST elevation MI, which is a little bit trickier. So they can have those elevated troponins, have all the classic symptoms, but not have those findings on EKG that are as classic. So there are criteria for how you treat a patient who has an ST elevation versus a non-ST elevation. So, again, lots of detailed things, but essentially, ERs, providers are going to have these protocols and understand what to do in each situation. But when you have that ST elevation, they're moving through the steps very quickly because we know it's a hard and fast diagnosis. So pre-hospital, before you get there, if you come in an ambulance, they're going to put an IV in you. They're going to give you that chewable aspirin, tell you to chew it. And it won't be a baby aspirin. It'll be full strength, 325, when you're having the actual heart attack. They're going to give you nitroglycerin, which dilates blood vessels. And they're going to stick some leads on you because usually they'll be paramedics, and they're going to throw some oxygen on you. When you get to the hospital, we always say Mona greets you. So it's just how you remember it. So it's morphine, oxygen, nitroglycerin, and aspirin. So if you came via ambulance, you already got some of that, but you get the morphine when you get there. It doesn't matter what order. All those things are happening at the same time, basically. And then, if a patient gets there with that STEMI, that very classic, the goal is to get them in within 90 minutes into a cardiac catheterization lab. So that is why those protocols are there, because it's code, whatever, and boom, 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 we go straight for it. And, that helps to help their outcome.
I'm smiling because I know certain hospital systems are moving away from using codes and just announcing what the emergency is, which I have feelings about, but I also understand wanting to be transparent. But a hospital system I worked at got rid of codes and would just say, cardiac emergency, this floor, whatever, things like that. And I understand it because you don't want people to panic. I think a lot of it came to advent with, we had certain codes for active shooter, certain codes for, those more external emergencies. And then people were like, well, what does that mean? What does that mean? Where everybody's heard like code blue.
Right.
So I know that was some of it, but it's not always necessarily helpful to then be announcing that someone is dying on a floor. That's not going to necessarily help people either. So
yeah, no.
Yeah.
So, once they get this going, if the patient is more than 120 minutes from a facility that is capable of doing a cardiac cath, they can also do something called fibrinolysis, which is using certain medications that can help dissolve blood clots.
How rare is it to not be near a cardiac cath lab? Because I feel like every hospital I've been to has one. Some certain cardiology offices have them. Like, is it that rare these days?
It kind of cut out, but I kind of got to asking who doesn't have the capability to do cardiac cath. I think a lot of that has to do with also these are private cardiologists who are in their office seeing patients or doing procedures. Not everybody's got the interventional cardiologist physically there and ready to go. I'm sure there's somebody on call. A lot of community hospitals aren't going to have that capability. They can use them for outpatient elective catheterizations, but aren't ready for, that emergent. I guess the bigger centers are more likely to have somebody there all the time.
Yeah. And I guess I take for granted that we're in a metropolitan center that has a lot of emergency centers. We have a lot of access to these services nearby, whereas people in more rural areas probably don't.
Exactly. Definitely. So, but the advent of having coronary care units have really, improved mortality rates and reduce them significantly. So, having these protocols set up does help. And then there are certain things that, once we've gone through and we've done that urgent catheterization, that's going to happen during the hospitalization and upon discharge. And there's still more I have to cover. I have a lot of notes. I'm sorry. But we are going to immediately start a statin, which is a cholesterol medication. And we are going to start a P2Y receptor, which is usually basically something that works along with aspirin to stop those platelets from clumping. And typically, you're also going to put patients on certain medications, like we mentioned before, a beta blocker, which slows down the heart and reduces the demand of the heart, and something called an ACE inhibitor, which helps with what we call remodeling of the heart after a heart attack. Okay. So, if someone, we kind of cover the STEMI cath lab, go straight there. While they're in there, if they can do a stent, which I'm going to go to in the next segment, they will. But just really quick, what happens to those NSTEMI patients? They get put on all the medications and they still, get monitored. And they will typically have an echocardiogram and a stress test while in the hospital. And then a non-emergent catheterization if that's indicated, and then often be discharged on similar therapies than those STEMI patients had. Okay. So, what is a cardiac catheterization? Really quickly, basically, it is a procedure where an interventional cardiologist is going to make a tiny little incision in your groin and go through a large artery there, thread this catheter all the way up to your heart, and they're going to look at those tiny little arteries, and they're going to see if there's any blockages. And if there's an area that is blocked, in a short segment, essentially, they can do what's called an angioplasty, which is a balloon that sort of stretches it out, and then they put a stent in there to keep it open. Sometimes you go in and you find diffuse disease, which means all along the pipe there's plaque, but there's not one spot that is a certain percentage that's stentable. So you can't always fix things. Or it's that such main vessels are involved in such extent to the disease, then they're going to need that actual surgery, open heart bypass surgery. So bypass surgery, we call it a cabbage, and a coronary artery bypass graft.
I thought it looked like a cabbage or something. I thought it was going to be cute, but no.
So basically what that is, two ways. The most common way is they cut your entire sternum open, literally crack your chest wide open. They put you on a bypass machine, which means that your blood goes through and gets oxygenated outside your body while they're working on your heart, which is pretty scary to think about, but it's a well-oiled machine, we'll say. And then what they do is they take a blood vessel from somewhere. Sometimes they harvest it in your legs. Sometimes they use a mammary artery. So they just mobilize that from the chest. And they essentially bypass the blocked area. So they attach at this end, they go around, and then they attach at the other end, essentially to get new blood flow through. And cabbages are done sometimes in these emergent circumstances, but sometimes they're done about somebody who you find out about the coronary disease before they got to the full-on heart attack. It can be done before that happens. So that's often another way you'll see it. Mm-hmm. And then the one that Robert had was that I didn't know too much. I've heard of it, but I didn't know too much about it, is that endoscopic. So essentially, instead of cracking your entire chest, similar to how we do a laparoscopic surgery on the abdomen, you're making tiny little incisions. And they're actually using like a Da Vinci robot, so they can have very precise movements and technology to do the surgery in a smaller area without having the big chest open, which is nice because the recovery for the patient is going to be much easier.
But imagine too, some of those surgical risks are reduced, infection and all that stuff is reduced significantly the less you're kind of cutting people open and having more than one hand digging in there.
Right. Absolutely. Again, where is it available? Is it available in the center that's closest to you? An academic center, somewhere like that, is more likely to have it. A tertiary center, as we said it.
I would imagine too, in 2025, places have at least a center close enough, unless this is like an emergency and you have to have something done immediately.
Right.
But I feel like you're planning it.
Right. And there are, like, I know in New Jersey, here and there, this is the hospital that does these, but not everybody does, like literal, local hospital doesn't do open heart surgery, right? So you're going to have to be transferred to their sister or hospital that's bigger. So there's still like movement that typically will have to happen.
Yeah. And I can imagine depends on, the need. If this is something that is an emergency, if it's an emergency, you don't care how it's going to be done as long as it gets done. Versus
Right.
if this is something you can plan ahead for, then you might want something that has an easier recovery time.
Yes. So, what are our risk factors? What makes somebody at risk for coronary artery disease? So
all the things that I have.
Yes and no. You don't smoke.
That's true.
Right?
Don't have, don't, and never have, luckily.
Right. So family history, smoking, diabetes, high blood pressure, high cholesterol.
My blood pressure tends to be low, so lucky me.
There you go. See? And then, in men, the risk increases around age 45. Women, it's not typically increased till about 55, typically after menopause, because hormones, female hormones are protective. And so, a big part of what we do is what we call primary prevention. We don't want to get to that point. So like literally 90% of my job is primary prevention for heart disease. Like that's what I talk to people all day about, because my whole point is to never get there. So making sure we keep your cholesterol, your sugar, your diabetes well controlled. And of course, stop smoking, which is probably the biggest risk factor and the hardest one for people to do if they've been smoking. Family history, plays a role. Obviously, you can't undo that or change that or prevent it. And we don't really have a way to factor that into sort of our calculations of your risk. So yes, my brother, my father, my grandfather, they all had heart attacks. I'm going to screen you, and I'm going to be a little more aggressive. But there's not like a perfect guideline for that, because it's just not something we can measure. So, that would be primary prevention. And then secondary prevention would be somebody who now we know has coronary disease or has had an event. And again, now preventing a second event. So it's all the same things. We just call it two different things, and guidelines may be different. So aspirin used to be recommended for primary prevention. It is no longer, was it 2 years ago or so? It's only recommended for secondary prevention, meaning somebody who's had a heart attack or a stroke or has peripheral vascular disease, they would be a candidate to be on long-term aspirin. But you or I, who've had no events, the outcome of us taking aspirin every single day does not outweigh the risk of taking aspirin every single day, because there are risks of GI bleeding and such.
That's what I was going to say. I'm sure there's other complications that if you don't have this risk, you don't want to start taking it for that.
Exactly. And then we are going to cover this in a very, very soon upcoming episode, but there are other drugs who now have indications to help prevent coronary disease and prevent events. So the GLP-1s, which we will talk about, not going into detail, but GLP-1s, three of them, I believe, have this indication. More detail on the next one, but the one you hear about the most right now is Ozempic, has that indication, and as well as its counterpart Wegovy, the weight loss version. And then the SGLT2 class of drugs, which you don't hear as much about because they aren't so magical and all over the news, but they also, some in there, I think there's 3 in that class that can reduce cardiac events. That would be Jardiance, Invokana, and Farxiga. So they also have indications to prevent heart disease and heart failure.
I'm laughing because I can hear like the song for the Farxiga commercial in my head. Do, do, do.
And then, the last thing that has proven data medication-wise would be 2 of the statins that have these studies. So what's interesting is back in the day, the old statin cholesterol medications, simvastatin, pravastatin, there are a couple other ones, they lowered cholesterol, but they didn't have any outcomes data. So they can lower the cholesterol all they want, but if they don't prove that they reduce the risk of cardiac events and death, then what's the point, right? So the 2 that have that are both generic now, but one is Lipitor, which is a atorvastatin, and Crestor, which is rosuvastatin. So they're basically the ones that you will see every single patient come out of the hospital on. You will see most people prescribing them first line because they actually have the data. So, as we just said, kind of what do? Lifestyle, don't smoke, keep your blood pressure, cholesterol under control, see a primary care provider, see a cardiologist if you need to. There is something called an ASCVD calculator that you can Google. I use that every day. I put in your blood pressure, your age, your cholesterol numbers, if you're diabetic, if you're a smoker, and it tells me your risk of heart attack or stroke in the next 10 years. So anyone who's over 7.5% risk, we typically say we really should be on a cholesterol medication. Anyone who's over 10% risk absolutely positively should be. So that's something you can do on your own, is like go Google ASCVD and figure out what your risk is.
Not CBD, ASCVD.
ASCV is in Victor, sorry, cardiovascular disease. And last thing, because I know I've been talking a lot, some tests that you may do in that prevention screening portion of things before an event ever happens would be a stress test. So that could be an exercise stress test where you actually walk on a treadmill, get your heart rate up, and see if your heart muscle continues to respond or your EKG shows changes. Or you're laughing at me.
I'm laughing because I had one last week, and I had my knee was like all like tight, and I was like terrified that like that was going to make me like look like I can't do it. And of course the stress test came back fine, but like the whole time I'm like limping on it. I'm like, I could do it. I could keep going. I can keep going. I'm fine. And it was fine.
So in that circumstance, for someone who's got an orthopedic issue, we would do a nuclear stress test usually, which is where they inject you with medication. Then that makes your heart rate go fast. And then they, in addition to the EKG, they also do these special imaging. So that's one option. And then other things we do, coronary calcium score, which is fairly newish, and I've been using that quite a bit to risk stratify people. So that's a special kind of CAT scan that just looks at calcium buildup in your coronary arteries. And so it gives you a score, and sometimes you can see which artery the buildup is in. If I see it all in that LAD, the widowmaker, I'm a little more concerned.
Right.
You know, the advantage of that is it's quick, it's easy, it's inexpensive. Most places you can even cash pay for that test for under $100. So it's pretty accessible. And it gives you some quick information. The only thing about that is it's not 100% because you can have soft plaques that are not calcified. And so it's not going to see those. Mm-hmm. There is a little bit more of a detailed version, which would be a CT angiography. So it's still a CAT scan, and it gives a little more detail of the vessels. That is going to give you a little more information, and we'll see some of that soft plaques. And then a couple other newer things they're doing is a PET scan. These are things that cardiologists are typically ordering for something very, very specific. A PET scan uses a radioactive tracer to look at the way things light up on the heart. I'm not going to give you details because that's a cardiologist test. But these are things that you may have ordered by a primary or a cardiologist prior to hopefully ever having any event and hopefully figuring things out and fixing things. You can have that catheterization. You can have that bypass before you ever have a heart attack. I did a lot of talking.
You did, but that's okay.
But we did it.
I did a lot of listening.
And, you know, we had some glitches in the beginning and then it kind of smoothed out. So I will hopefully in editing get rid of all the weird, awkward pauses.
No, leave them in. Make it awkward for everyone.
Yeah. You can be awkward with us.
Yeah.
So just to reiterate that contest that we're going to do on Instagram, look at our Instagram page for details, but do post a little picture, screenshot of you listening, saying, I'm listening to #medical media mixer in whatever location you're in. And you'll get a cool prize. You'll be entered into a raffle to get a cool prize.
Yes. And maybe if we can plan accordingly, we'll winner on the podcast. Like while we're recording, we can pick and announce the winner then.
Yeah. All right. We'll try and make that all plan out time-wise with timelines.
Or we could just record just a piece of that, just the two of us picking the winner and then filter it in.
Oh, awkward pauses.
No, you're the awkward pause. You're an awkward pause. Your face is an awkward pause.
All right. So follow us on Instagram, TikTok, YouTube, Facebook, Pinterest.
And you can send us your emails to medicalmediamixer@gmail.com. Still no one has emailed me. I'm super sad, guys. Please send me an email.
Do we need to give them like direction what to email us? Email us?
Email us, hello, I'm listening.
Things you've
email
watched?
us, things you've watched. topics that you're curious about and you want us to explain, email us pictures of your pets. I don't care. Just send us an email. Anything. Let us know that you're out there, because I feel like I'm just talking to Tara, and with the awkward pauses, I'm talking to myself. See?
We do have stats. We have listeners. We just need, them to contact us and interact.
We're not related to all of our listeners. We have other listeners.
Yeah, true. I don't know if I could put a disclaimer that somebody who wins the contest can't be related to us, because probably a decent proportion of our listeners might be related to us.
It's half of the people we know. Okay. I think we're done for today.
I mean, all right, no one in our own households can win. Okay.
Fair. That's fair.
Awkward pauses.
Okay.
I'm going to have fun editing this.
Yes. So, shall we?
All right. Yes.
This is you.
I don't remember who goes first. Thank you for listening to medical. Thank you for listening to Medical Medium Mixer.
The perfect cocktail. Cheers.
Cheers. I'm cheersing myself because I can't see you.
Oh my God.
Okay, that's going to be fun. That's going to be an interesting edit. Yeah, I think I'm going to
did you stop
order the proper
I don't think you stopped it.
Oh, no, I didn't. Wait, let me hit stop.
Keep that in.
Stop.